Thank you, everyone, for joining us. My name is Jess Molesky. I am the benefits specialist here at the consortium. Today, we have with us Jason Warchall from Excelis Blue Cross Blue Shield and Dr. Kathy Robischon. I am going to turn over to Jason now to introduce Dr. Robischon and get us started.
Thank you so much, Jess. Hi, everybody. Good afternoon. Thank you again for hosting Excel's Blue Cross Blue Shield and our esteemed colleague here at Excel's Blue Cross Blue Shield. So just wanted to highlight Dr. Kathy Robischon. She is our Vice President of Medical Affairs and Clinical Services. Dr. Robischon is the Vice President of Medical Affairs here at Excel's Blue Cross Blue Shield. She provides clinical leadership and expertise to several areas of focus within the health plan, of which does include the affordability and program development, utilization management, and quality programs. Dr. Robichon serves as the co-chair of the health plan's corporate medical policy committee and is engaged in medical policy development. Dr. Robichon is also engaged nationally with the medical policy panel and medical policy operations forum at the Blue Cross Blue Shield Association. Dr. Robichon attended Colgate University, where she played Division I soccer and softball. She received her medical degree from UMDNJ, Robert Wood Johnson Medical School. She completed her residency in OBGYN at the University of Rochester Medical Center, Strong Memorial Hospital, and is a board certified OBGYN. Dr. Robichon was in private practice in Rochester for over 22 years. Dr. Robichon does live in Pittsburgh, New York with her husband and three boys. They love to travel, play pickleball, biking, and downhill skiing. In terms of corporate areas of accountability, so her expertise in affordability, value-based payment programs, utilization management, medical director team operations, quality programs, dental strategy, and women's and maternal health and equity projects. So very, pleased to have my esteemed colleague here from Excel's Blue Cross Blue Shield. I am going to turn it over to Dr. Robichon, and I'm going to be sharing the slides. So bear with me 1 second.
All right. Thank you so much, Jason. I probably need to pay attention to that bio. Wow. But I am so excited to be here. I really love this topic and it affects so many of us. So I'm hopeful that I can talk to you a little bit about menopause, give you some information, empower you as we move through this journey and answer any questions that you may have at the end. So if we can move to the next slide. We're going to cover some statistics about menopause, the stages of menopause, understanding what's happening both hormonally, symptomatically. We're going to talk about management and treatment, what we can do about managing menopause, and hopefully I will leave you with a better understanding of what's happening and leave you feeling empowered to face the menopause transition a little bit better than when we started. Next slide, please. So what is menopause? By definition, menopause is 12 consecutive months without a menstrual cycle. The average age of natural menopause in the United States is 51. In the United States, more than 50 million women are somewhere in this menopause transition. The duration of menopause is typically between 8 to 10 years. It can vary considerably. For some people, it's shorter. For other people, it can be much longer. We'll talk about that more as we go through the talk. And then about 5% or more of the population has an early menopause for reasons that we're not quite sure about. Next slide, please. So perimenopause can be wildly unpredictable. Periods change dramatically during this time. They can become much heavier and more frequent, or it can go the other way where they're lighter and less frequent. It's just a very confusing time. It often catches a lot of us by surprise. So no, it's not just you. It's happening to all of us. As I said, the transition can take about 8 to 10 years. While most of us will start in our mid-40s, some people will start sooner, some will start later. The pre-menopause part of it is typically broken down into two phases. There's early pre-menopause. That time is typically when you're still having normal periods. You may still be ovulating. You may still be able to get pregnant, but you're having like hot flashes or night sweats. The next phase is really the late premenopause, and that's when your periods start to get irregular and maybe some of those symptoms are getting worse. Then there's menopause, again, typically that year. And then there's early postmenopause. Those are the first 4 years after your periods have stopped. And then late menopause is the rest of that time. And we're going to talk a little bit more about this as we go through. Next slide, please. Thanks. So the way a woman's cycle works during reproductive years, the ovary requires some gonadotropins from the pituitary gland called FSH and LH to stimulate the ovary. What that does is it stimulates oocytes or eggs to develop. Those eggs start to secrete estrogen and progesterone. The whole process is preparing for ovulation, possible fertilization, and implantation of an embryo. In menopause, there are changes to the FSH and LH levels. And what happens is there's reduced stimulation of the ovary. It's not enough stimulation to make oocytes. The ovary starts producing less and less estrogen and progesterone. It results in not releasing an egg, no ovulation, and obviously no fertilization and pregnancy at that point. Estrogen does do a lot of really important things in our bodies. Certainly prior to menopause, it is protective to our hearts. It keeps our cardiovascular tissue healthy, helps to manage blood pressure, and also helps to keep lipid levels healthy. It protects our brain by helping to maintain proper blood flow. It also assists with memory and fine motor skills. Estrogen is important in lean muscle mass and bone density, protecting against osteoporosis. Also, estrogen has been shown to boost mood by helping to keep serotonin levels stable. And estrogen also improves sexual function by keeping vaginal tissue healthy and promoting vaginal lubrication. Progesterone also does very good things. Its primary function is to stabilize the lining of the uterus for an implanting pregnancy, but it also works on helping with mood. It supports thyroid function, and progesterone is very important after you have a baby to help with lactation or breastfeeding. Next slide, please. Okay, so menopause affects almost every aspect of a woman's body, head to toe. Low systemic estradiol concentrations can lead to what we call vasomotor symptoms, hot flashes, night sweats, in about 75% of women. And we know that estrogen treatment can be an effective way to manage this. We'll talk much more about that later. About 50% of postmenopausal women will develop symptoms of vulvovaginal atrophy, vaginal dryness, painful intercourse. We call that collectively genitourinary syndrome of menopause, and there are some treatments about that too. So you can see all these symptoms all across the board. Some we know very well. We've talked about hot flashes, irregular periods, vaginal dryness, decreased libido, mood swings, weight gain. But there's some things that are also affected that don't get as much attention right now. We know that as women go through menopause and estrogen drops, they're at increased risk for osteoporosis, heart disease, bladder incontinence, and bladder infections due to changes in that vaginal tissue. There's also some things that are happening that aren't quite that common, something called burning mouth syndrome. The oral mucosa is very sensitive to estrogen, and as that estrogen levels drop, you can develop this burning mouth syndrome. It can cause burning, dry mouth, and even altered taste. There are many ways to treat it, sometimes hormone replacement therapy, sometimes with saliva substitutes, or even with vitamins and minerals. We'll talk about that a little more too. Another area that's starting to get a little more attention is estrogen has such a huge anti-inflammatory effect on our bodies, especially in our connective tissue. It promotes elasticity, strength with our lean muscles. As estrogen drops in the perimenopause and menopause, it can lead to increased joint pain, and we will sometimes start to see exacerbations of tendinitis in areas of potential overuse. So think of our the joints that we use a lot, our shoulders, elbows, wrists, hip, knees, ankles. One of the things that we're seeing a lot now is something called gluteal tendinopathy. This is an extreme pain in your hip. A lot of women have been misdiagnosed with osteoarthritis because of this. Um, and so the treatments are different. You can use physical therapy for both of them, but honestly, if you get an x-ray of somebody who's got gluteal tendinopathy, it'll show a normal hip joint and they will have this intense pain. So sometimes hormone replacement therapy can help that, sometimes physical therapy as well. We're going to stay on this slide because we're a little bit ahead of where I'm talking, but I apologize for this not being easily readable. The purpose of this slide is to show how menopause happens differently to different ethnic groups. We look at the average age of menopause, the most common symptoms, and the most severe and most frequent symptoms. And while many of them are similar, it goes to another point I'm trying to make in this talk, and that is we all experience menopause differently. We do not have the same symptoms. And we know that Black women enter perimenopause and menopause at earlier ages than their white peers. They tend to have longer perimenopause, menopause transition experience, and tend to have much more intense hot flashes and vaginal symptoms. And there was a study that was done not that long ago called the SWAN study. And the SWAN study showed that the average duration of menopause-related hot flashes and night sweats was about 6.5 years in white women, non-Hispanic white women. It was about 8.9 years in Hispanic women and about 10.1 years in Black women. And the reason I want to bring this to your attention is we know the benefits of estrogen during our premenopausal life in terms of our cardiovascular protection. For women going through menopause at a younger age or for a longer period of time and not having it treated, they are setting themselves up for increased risks of cardiovascular disease, osteoporosis, and even dementia. So we want to make sure that you are being adequately identified, that you are getting the treatment that you need, and that you're not suffering in silence. Again, big point here. If we can move on to the next slide, we're going to talk a little bit about menopause and your health, and we can quickly jump to the following slide. So this slide is meant to show did I miss a slide? Okay. The cardiovascular risk factors that are associated with menopause. We know that estrogen works well for our cardiovascular system, beneficial to our blood vessels. It helps with lipid levels, keeping the HDL or good lipids elevated and the bad HDL all good things. As you go through menopause and those estrogen levels drop, you start to see thickening of the arteries and they become stiffer. We also start to see some weight gain, especially around the abdomen. And there's even increases in what's called visceral fat. That's the fat around our organs. All of these things are problematic for developing diabetes and cardiovascular disease. This risk score is going to be something that we're going to use later on, but it's called the atherosclerotic cardiovascular disease risk assessment tool. And I can't even say that one time fast. I'm not going to try more than one time. But this helps us to look at an individual specific risks for cardiovascular disease associated with aging. So we look at past medical history. Do you have high blood pressure? Do you have diabetes? Do you have hyperlipidemia? Do you have an autoimmune disorder? Do you have HIV? We look at pregnancy history because that's important. Did you have preterm labor? Did you have high blood pressure or diabetes of pregnancy? Did you have preeclampsia or eclampsia? Did you develop postpartum cardiomyopathy? We also look at family history. Do you have a family history of heart disease, heart attacks, strokes? What's your social history like? Are you a smoker? Do you drink alcohol? What's your lifestyle like? Do you exercise or are you more sedentary? And then we can look at biomarkers as well. We look at blood pressure, we look at BMI, weight, waist circumference, which is an important measure, look at lipids and glucose, and we put this all together and it gives us this ASCVD risk score. And I'll talk to you more about that as we go into how we're going to treat people. But this is something to think about. It really is individualized. The risk score usually is less than 5%, you're low risk, 5 to 10%, you're intermediate risk, greater than 10%, you're high risk. All right, we're going to go to another area where things get affected by menopause. Remember that slide where we're looking at all the symptoms of menopause, and I talked a little bit about how it's the ovaries that secrete estrogen and progesterone. But some of the things that are happening really in our brain. The symptoms of menopause, the hot flashes, because it's related to body temperature regulation. Night sweats, very similar. Anxiety and depression and insomnia, all related to what's happening in our brain. Brain fog, memory lapses. We know that premenopausally, estrogen's helping our brains. We know that there are estrogen receptors involved in learning and memory in the prefrontal cortex, the hippocampus, and the amygdala. We know that estrogen helps the brain regulate energy levels, it supports our immune function, and it promotes cellular growth and communication. So lots of things happen during perimenopause and postmenopause that disrupt this related to lower or fluctuating levels of estrogen. And that's what leads to this sort of terrible catch-22 of insomnia, brain fog, memory issues, sleep issues. It becomes a vicious cycle. And we're going to talk a little bit about how we can manage that down the road when we talk about treatment. Another area that is affected by menopause is our bones. And our bone density actually naturally declines as we age. We actually hit our peak bone density at age 30, and then it's a slow decline till you hit menopause. The reason is that we have estrogen in our bodies that is promoting bone growth. Estrogen actually stimulates osteoblastic, which is bone forming cells, to make bone. As we hit menopause, that stops, and we're at risk for our bones thinning, which is osteopenia, or very thin bones, which is osteoporosis. We worry a lot about women who go through menopause before the age of 45, because that's a much longer time that they're dealing with low estrogen levels. And we want to make sure that we're treating them appropriately so that they're not at increased risk for osteopenia and osteoporosis. We do know that diets low in calcium and vitamin D can weaken bones. Lack of weight-bearing exercise can help to reduce bone strength and density. There are some medications that you take that can affect your bones adversely. Long-term use of corticosteroids like prednisone, using some anticonvulsant or anti-seizure medicines can do that. Certain diseases and the medicines you use with those diseases can do it. Rheumatoid arthritis, thyroid disorders, and diabetes can affect bone. So this is part of why it's really important that your healthcare provider understands what's going on with you, past, present, to make these future decisions. One of the ways that we manage or identify bone loss is through something called a DEXA scan. It actually measures our bone mineral density. And it gives you a score. It's called a T-score. If your T-score is minus 2.5 or worse, that's osteoporosis. And that's something that we would talk about other treatments for, not what we're going to talk about today, but more intensive treatments. You also get another score called a FRAX score, F-R-A-X. And this is an estimate of your 10-year fracture risk. It takes into account the results of the DEXA, the bone mineral density, and clinical risk factors, some of which we talked about earlier. And having this information can really help us understand what needs to happen to improve bone. And if we go to the next slide, I'm going to talk a little bit about what we can do for our bones. We know calcium and vitamin D are essential to bone health. Our bodies can't make calcium, so calcium is an essential nutrient, meaning we have to get it from our diet or through a supplement. And it plays so many roles in our body. It's involved in muscle contraction. Obviously, it's involved in bone health. It's involved in regulating nerve function. So if you don't have enough calcium in your body to do all these things, it's going to go to the source in your body it can get it, and that's your bone. And it's going to stimulate even more bone loss. So we want to make sure that we're getting calcium and vitamin D appropriate in our diet. I'll talk a little bit about vitamin D. Vitamin D is also important for bone health. It actually promotes calcium absorption in our gut. For calcium, the recommended amount is about 1,000 milligrams a day till you hit menopause, and then it's about 1,200 milligrams a day. Dietary sources, there's calcium fortified orange juices, yogurt, Greek yogurt, great sources of calcium. Milk, soy milk, very good. Kale, the green leafy vegetables, spinach, tofu, all very good sources of calcium. For vitamin D, we recommend from about 19 to 70 that you get 600 IU. After age 70, we wanted to up it to 800 IU, just related to some absorption issues. And good sources of vitamin D, salmon, tuna, trout, obviously milk, mushrooms. Who knew mushrooms were a great source of calcium? But all of this is important to make sure that we are working to maintain healthy bones during this time. And we'll move to the next slide. Everybody's favorite. When it comes to maintaining a healthy weight, estrogen is actually our ally. It actually supports fat and glucose metabolism. It actually curbs appetite, and it can help us hang on to and develop lean muscle mass. So when estrogen drops in menopause, we start to see these changes. We may not have altered our diet. We may not have altered our exercise, and yet we're gaining weight. And some of this is because our metabolism is changing. We know metabolism starts to slow down as we age. It kind of accelerates at menopause, and really starts to make it that much more difficult to maintain or lose weight. It is a common complaint of women going through the menopause transition. We'll talk a little bit about diet can be very important. Certainly a low carb or ketogenic diet can help because it keeps insulin levels low, and that can help reduce abdominal and visceral fat. Getting enough protein can be important because that helps with maintaining lean muscle mass. It also can curb appetite a little bit. And if we go to the next slide, I can talk a little bit more about, there is no magic menopause diet. Nutrition is a key strategy for supporting our health during perimenopause and menopause. Eating well during this phase of life may help to mitigate some of the symptoms of menopause. We know that it can lower the risk for chronic conditions, help manage our weight and kind of improve our overall well-being. Lots of changes happening to our bodies, and it tends to feel almost self-defeating when you see what's happening physically and feel like you don't have control over it. So really the best menopause diet is a nutrient-dense diet. We want it to be well balanced. The Mediterranean diet typically is the one that comes to the top of the list, just based on it has a lot of the macronutrients that we want you to have, complex carbohydrates, protein, fat. I think the biggest thing to avoid is this ultra-processed food. That's the food that tastes good and kind of hits our brain in a way that makes us feel good, but it really has no nutritional value. And that's where we get into some trouble. You want to focus on, with the Mediterranean diet, the focus is on fruits, vegetables, nuts, seeds, whole grains, oils like olive oil, omega-3 fatty acids. Typically, you can get those from some of the oily fish. Another thing about omega-3 fatty acids is that we cannot make them in our bodies. We have to get them from supplements or food, and they're really important across many aspects of what we're doing. So this kind of just talks about the proteins, the carbs, the fats, veggies, Drinks, again, it's really looking at, I would say water, water, water. I don't think any of us really get enough water, and that's a huge part of keeping ourselves healthy. Another component of this that's emerging, especially in menopausal women, is gut health. Um, we're looking at fiber. Fiber is a prebiotic. These are the non-digestible fibers and compounds. They actually feed and stimulate the growth of the beneficial bacteria in our gut. So they enhance the diversity of our gut biome. They improve calcium absorption, and they support our metabolic and immune health. And so when I'm talking about prebiotics, it's apples, artichokes, legumes, lentils, beans, nuts, whole grains, all great sources. The other side of that equation is the probiotic, and that's probably what people hear about a little bit more. This is the live bacteria in our gut that are beneficial for maintaining and restoring a healthy balance of gut flora. We need that to improve digestion, to support immune function, and it can actually reduce some of the symptoms related to irritable bowel syndrome, bloating, and even mood disorders. And the probiotics are like yogurts, kefir, kimchi, kombucha, pickles. All of those are really good. All right, we're going to move to the next slide. Now we're going to start talking about treatment options. And yeah, we're going to start with menopausal hormone therapy. This is the broad term that we use to describe both unopposed estrogen for women who've undergone a hysterectomy, and estrogen and progestin therapy for women who have an intact uterus. We need progestin for these women because we want to prevent estrogen-associated endometrial hyperplasia or endometrial cancer. And the primary goal of menopausal hormone therapy is to relieve hot flashes. And it is actually the only FDA-approved indication for using menopausal hormone therapy. It does a whole lot of other things, but the FDA hasn't said it can do that anymore, or it can't do that right now. Many different forms of hormone therapy. They come as patches, pills, tablets, creams, gels, vaginal rings, suppositories, vaginal creams. We're going to talk about who we think should use these things and why, and how they should use it. But again, the idea is some of these typical menopausal hormone therapies come from an interesting source. They're called conjugated equine estrogens because they come from pregnant mare serum or urine. So always a weird thing to tell somebody that's what they're getting, but it's only one form of it. There are other synthetic estrogens and bioidentical estrogens that we'll talk about a little bit later. And one of the things I want to point out is on November 10th, 2025, the FDA announced revisions to the safety labeling for menopausal hormone therapy. And there were black box warnings that they removed. So they removed the black box warning for cardiovascular disease, breast cancer, and dementia. And the reason is that these black box warnings came from the Women's Health Initiative study that was done back in the 90s and maybe early 2000s that said there was a risk. The problem with that study is it was done on women who were 65 to 79, not women who are going through menopausal transition. We're talking about women in their 40s and 50s who have very different risk factors. So they've also removed reference to endometrial cancer. I think that's a little TBD. They've also removed the recommendation of lowest dose for shortest amount of time, which I think is actually a good thing. The current warning for breast cancer has not been removed, and I think that's because we still don't know really the true story about systemic estrogen therapy and breast cancer risks. So that's something we're going to have to keep looking at and determine what we're going to do moving forward. Quickly, I also want to say that there's progesterone therapy and testosterone therapies available as well. Okay, so this is this shared decision-making tool that I think can be very helpful for deciding to personalize who should get menopausal hormone therapy. And typically we're talking about people who are having symptomatic, disruptive, hot flashes, night sweats, mood swings, anything that's related to estrogen in menopause. And on the right side, the high risk group, I'm telling you, these are the people I'm never going to give estrogen to. Someone who's had a pulmonary embolus or a deep vein thrombosis, if you've had a stroke or a transient ischemic attack, you've had a heart attack, you have congenital heart disease, or you have coronary artery disease, peripheral artery disease, or a 10-year ASCVD over 10%, it's a no. And I'm not penalizing anyone, but we have other treatments that we can use, and the risk of estrogen is just not there. Low risk on the left side, those are the people I'm much more likely to give it to. They're in a category where if they're really suffering, this may be the best thing. And again, it's going to depend on what their symptoms are. Systemic therapy probably needs a pill, a patch, something that's going to go throughout their body. If they're having isolated symptoms, if it's really just painful intercourse, that can be treated with a vaginal cream or a vaginal ring. Again, they have to be relatively low risk. It's the intermediate risk where I struggle because there's some gray area here. Diabetes, it's going to depend. Are you a well-controlled diabetic? Maybe that's not a risk factor. But again, if you want to make sure you don't have any peripheral artery disease that would put you in the high risk category. Smoking, I'm not giving estrogen to anybody who smokes. So that's an absolute for me. High blood pressure, again, depends on how well controlled it is, any other underlying risk factors. Obesity, I don't have a BMI number in my head that says yes or no. It's all these factors together. Lifestyle matters. ASCVD between 5 and 10. Again, a lot of things to think about. High risk for breast cancer is a no for me. I just don't think it's worth it right now. We just don't know enough to put somebody at that risk. So I would say no. And again, there are other things that we can use that we're going to talk about that really may help those people more so than menopausal hormone therapy. Next slide. Okay, so there's bioidentical hormones. These are kind of hormones that are derived from plants and other sources. They're chemically similar to what happens in our bodies. They are created oftentimes through processes or in a lab. It is estrogen, progesterone, and testosterone, also in many different forms, pills, patches, creams, gels. And interestingly, the FDA has approved some forms of bioidentical hormones. For the estradiols, it's estrase, Climera, and Vivel. And for the progesterone, it's Prometrium. In this category, there's also compounded bioidentical hormones. These are hormones that are created in a compounding lab, basically based on a prescription that your provider would give. This was very popular for a while back in the 90s, 2000s. It may be coming back now. The downside of compounded bioidentical hormones is that they are manufactured and sold without FDA oversight for safety, quality, or purity. So that means you may be getting different formulations from 1 month to the next. And you may have some breakthrough symptoms because it's not exactly the same as it was before. So something to keep in mind as you're thinking about what you want to do with your provider down the road. This is actually one of the most exciting slides to me because these are non-hormonal medication options to treat menopausal symptoms. And I'm sure many of you have heard of Veozah. It's on TV all the time now. Veozah is a non-hormonal, it's a neurokinin 3 receptor antagonist, works in the brain. It blocks the neurokinin B, so that's in the brain's thermoregulatory center. That's actually in the hypothalamus. In menopause, we have these falling estrogen levels that disrupts the balance between estrogen and neurokinin B. That leads to hot flashes and night sweats. By blocking this, we can restore that temperature control, and it reduces both the frequency and intensity of hot flashes. It's in a pill form. The one caveat about Veoza is that it can't be given to people who have liver problems. So you have to get liver blood work done before you start it, and then pretty regularly while you're on it to make sure that it's not causing any problems with your liver. The nice thing about this is it can be used for people who have a medical contraindication to estrogen, breast cancer. They're in the high risk, ASCVD stuff. It's really a judgment call, or people who prefer not using hormonal therapy. They've had adverse side effects with hormonal therapy. So a very good option. There's also Linquit. This was actually just FDA approved in October of 2025. It has been shown to reduce moderate to severe hot flashes by about 74% in women, and also seems to improve sleep. It works a little differently than Veoza. It actually works on neurokinin 1 and neurokinin 3. And we think that that's going to actually help with mood and sleep. So also very beneficial. We also have off-label uses of medications. Antidepressants like SSRIs and SNRIs have been used for years to manage hot flashes. They do a very good job. We have gabapentin, which is an anti-seizure medicine, really effective for nighttime hot flashes or night sweats. Also, taking it at night, it tends to help make you sleepy, so your sleep is better. We have oxybutynin, which is an anticholinergic that's also been shown to reduce hot flashes. I tend not to use this as much because there's more side effects with anticholinergics, especially as women get older, that don't make it as beneficial a choice. And now the other thing is this emerging non-hormonal medication, cendifensine. It works on the monoamine system, which means it works on serotonin levels, norepinephrine levels, and dopamine. And it has some really cool things, not just helping with hot flashes, but it works on mood and on food cravings. So may have a really beneficial effect. It's only been through phase 2 trials, so they have to do phase 3 trials to confirm its effectiveness and figure out what the dosing would be and how safe it is. But another thing that would be a tool in our arsenal for managing a lot of the symptoms that go along with menopause. Okay, we all know we're supposed to exercise. It's really hard to make that a practice, at least for me. But exercise really can help with improving symptoms during menopause. It can help with sleep. It can help with mood because of endorphins. It can help with stress and energy levels. It can also help to lower the risk of some chronic conditions, such as heart disease, because it can improve our HDL or good cholesterol and lower our LDL or bad cholesterol levels. It works against osteoporosis with weight bearing, and can help prevent spine and fractures related to osteopenia and osteoporosis. We know strength training is important. We know that cardio has been shown to be really beneficial for women going into menopause, helps to minimize the risk for heart disease, and can also help with clearing up brain fog, also help with sleep. There was actually a large study from the Harvard School of Public Health that found that running for 15 minutes or walking briskly for an hour reduced the risk for depression across the board. There was another large study that looked specifically at midlife women and found that exercise, especially cardio exercise, improved both sleep quality and mood. So another thing that we can do that can help. Yoga is a great low impact way of doing exercise. We know it lowers blood pressure, and that regular practice of low yoga can improve sleep and the quality of life in menopausal women. High impact exercise, again, that's something that if you're not doing it regularly, I would not recommend it off the bat. You really got to check in with the healthcare provider, but that can be helpful for bones and long-term health. And I don't know, I'm a walker. I love walking. Walking is one of my favorite things. We know walking can help improve mood. It can reduce arthritis, pain, and stiffness, lowers blood pressure. One of the things that I really like about walking is you can do it with a friend. And typically, if you're walking with a friend, there's an accountability to it. You're not going to blow off your friend because you just don't feel like walking that day. It also gives you a chance for socialization, which is a huge part of what we need as we get older. So walking with a friend becomes something that you enjoy, you look forward to it, and then it's really an enjoyable habit that you can continue for long periods of time. Another area, we know that stress levels for women during menopause related to the body changes that are happening, the things that are happening hormonally, this stress causes cortisol levels to go up, which in turn can affect other aspects of our body and makes us have more difficulty dealing with stress. Using meditation and some of these stress relieving activities really does help. Be it yoga, be it meditation, be it massage, all of that has a relaxation component. There have been studies that have shown that regular meditation can reduce stress related cortisol levels by up to 25%. That's really significant. We know that meditation helps manage anxiety and depression. It promotes self-awareness, gives us emotional resilience. Mindfulness really is something that helps us to manage other aspects of our lives better as well. There have been studies that shown that there's also a reduction in hot flashes in women who practice consistent mindfulness. It promotes relaxation, reduces nighttime awakenings, helps with insomnia and sleep. And meditation before bed can really improve sleep onset and sleep quality. And the benefit of that is if you're sleeping better, you're going to wake up in the morning with less brain fog. You're going to have better clarity, better memory, possibly improve cognitive function. And I think it also helps us to take on a little bit of kinder, gentler self-image, where we're not quite as hard as on ourselves as we're going through this really life-altering transition of menopause. So this is another strategy that we can use to help us manage the symptoms better. Okay, next slide. So I want to reiterate my three main objectives from this talk. One is menopause is different for everybody. So we all have similar symptoms, but our menopause is different, unique. Also, women should not suffer in silence. This is not something that should be, talked about in whispers and that kind of thing. We need to be proactive and supportive of one another as we go and get whatever treatment we need as we go through this menopausal transition. And the third thing is treatment is not a one size fits all. It is unique. It's unique to the individual. We've got to do a shared decision. I need to understand what you want. I have to tell you what I think is safe. And we come to a conclusion that works for you and makes all of us feel like we're stepping in the right direction. I think there's a lot of stigma and embarrassment related to menopause. I hope that this talk helps to create safe spaces to start having those conversations. Not talking about menopause kind of plays into microaggressions around women being too emotional or angry or emotionally labile, which is just so untrue. And if we think about it, women aged 45 to 60 represent 20 to 25% of the US workforce. So there's a lot of people going through this. And I want to encourage you to share information, share educational information, resources. Hopefully your companies can help to support women as they go through menopause through education, opportunities like this, so that you really feel like you are well-versed in what's going on and able to make proactive choices for yourself. I also want to make sure you have the ability to discuss with a provider, either a primary care doctor, a gynecologist, a midwife, a menopause specialist, whomever, to understand what's happening to your body, what you can do, what you should do for your well-being and overall health. And if that person you're talking to isn't giving you the answers you need, you got to find somebody else. So next slide. I want to thank you all. My gosh, I feel like I could talk about this forever. And I do want to give you a chance to ask questions and see what I can do to answer them to the best of my ability.
Thank you, Dr. Robischon. That was very informative. And I appreciate the time you've taken. We do have some questions in the chat. It's kind of a multi-part, so I'll start with the first one. Why is the local medical standard to stop the monthly period using synthetic hormones rather than using bioidentical progesterone to support a natural monthly cycle?
So I don't know if that's the local medical standard. I will say, and you can see from the talk that there's lots of options out there. I think if you're talking about like reproductive age women, um, it may be, if we're talking synthetic hormones, are we talking about birth control pills? I think because we know that birth control pills help to suppress ovulation and reduce the risk of pregnancy. Um, Bioidentical progesterone can do that, but not to the same level that birth control pills can. And I think, like I said, with bioidentical hormones, depending on what you're using, if it's something that's FDA approved, that tends to go through a regulatory quality, safety, purity. But if it's something that's compounded, it does not have that. And that worries me a little bit about what you're getting from dose to dose. But again, I think it depends on what you're looking for. If you're looking for birth control, progesterone alone, it has lower efficacy for preventing pregnancy. It can still be used. And I think that's part of what you need to have a conversation with your healthcare provider.
Thank you for that. The second question is why is hormone suppression via oral synthetic pills taken nightly that go to your liver, blood, and hammer your brain the only treatment?
Again, it sounds like this is more like birth control pill. I think I'm again similar to what I said before. I I think the question needs to be what is the goal of the person taking the medication? Is the goal to prevent pregnancy? Is the goal cycle regulation? So there's a lot of things, and I don't know about his medical history. Are they even a candidate for birth control pills that have estrogen in them? Um, I think that it really is an individualized decision at that level as well, to know exactly what someone's trying to get out of this natural monthly cycle suppression. And again, that's part of why you need to have a conversation with your healthcare provider to understand that better.
Thank you for that. Do we have any other questions?
Oh, somebody talked about they had a hysterectomy and they're having this hip pain. Yeah, I would at least talk about the possibility of this gluteal tendinopathy. It may be osteoarthritis, but if you have an X-ray of your hip and it's normal, that makes me think that there might be something else going on, and it might require slightly different treatment. Again, physical therapy can help with both of them, but it's there may be other things that can be done for gluteal tendinopathy related to menopause.
It looks like there is a question. Are your slides something that we would be able to get and send out with our recording?
I'll have to check. I don't know what the Excelis policy is on this stuff, so
Okay.
let me find out and I can let you know.
Okay. Any other questions if anyone wants to throw them in the chat or unmute?
I mean, I really appreciate the opportunity for being able to speak with you. Clearly, you can tell that I'm passionate about menopause. I'm passionate about women's health. I do recognize that the menopause transition is really underappreciated sometimes and undertreated. And I'm trying to create some advocacy for you as you go through this to feel like you are armed with information that you can bring to your healthcare provider to discuss what options may be best for you.
Looks like another comment did come in related to the questions that you answered. Says, in my experience, many practitioners are taught that no period equals no problems, but my questions are about menopause, not birth control.
Uh, well, I understand your point. So I think historically, way back when, before the WHI study came out, um, hormone replacement therapy was a one size fits all, although dosing was different. But it was like basically once you went through menopause, you got hormone replacement therapy unless you had a severe contraindication and you were on it for life. There was no real understanding of individualizing therapy. And I think what we're recognizing is there are consequences to women who get no therapy after they stop having periods. And the whole point of this is there's so many things we can do. Hormones are one component of it. Non-hormonal medications are another. Diet, exercise, meditation, all of that is part of what we can do. And one of the things, I just don't think that there's a lot of practitioners out there that are well versed on this and able to meet the needs of women when they are struggling to go through this. And I think that that's changing a little bit now. I think that there's definitely like more apps out there that deal with uh, menopause specifically. I think that employers are looking to meet the needs of their employees a little bit more in offering other opportunities to have access to menopause treatments and menopause counseling that we may not be providing with our practitioners. So there's lots more coming and lots of information. I think we're evolving a little bit to be a little more inclusive of all things. And, as we live in a technological society, um, things are at our fingertips. Our phone is a crazy computer and we have access to a lot more information. And, part of what I'm doing is trying to provide education for what is out there and my approach to how women should not be silenced or stigmatized or put in harm's way by not treating what should be treated.
Thank you. Response to that was, thank you. I'll keep looking. Maybe I'll find someone like you. Another question did come in. I am on a bioidentical estrogen and progesterone. Would you also recommend the non-hormonal treatments with the bioidentical?
So, great question. Uh, I would say that's something that you have to be careful about, and it would depend on what's happening symptomatically. If the bioidentical hormones you're still having breakthrough symptoms, that might be something to discuss with your provider. I think it depends on which non uh, hormonal treatments you're thinking about. And we don't want to do anything that's going to put you at increased risk. And again, a lot of it depends on all those factors, your past medical history, knowing what risk factors are that you have as an individual, and what your goal is. What are you trying to achieve through treatment? What symptoms are we trying to alleviate? So again, that requires a conversation with your provider to understand better. Again, right, compounding is a struggle because, it just doesn't have that dose to dose equality that some of the other products do have.
All right. Thank you again for your time, everyone, with your questions. They've all been great. We will be sending the recording out, and Dr. Robischon will find out as far as the slides. Just a reminder to keep an eye out for all of our other upcoming webinars, wellness challenges, and activities that we have going on. Thank you again, Jason and Dr. Robischon, and everyone else. I appreciate you taking time out of your day to be with us for this presentation.
It was my pleasure. Thank you so much. Have a
Thank you,
great day.
everybody. We'll see ya.